Good evening guys, today we are learning about hypolipoproteinemia. In this there are mostly 4 types of disorders. 1 and 3 are alternative autosomal recessive and 2 and 4 are autosomal dominant. So in type 1 hyperchylomicronemia is autosomal recessive disorders. There is defect in lipoprotein lipase or ApoC2 deficiency. There is increase in chylomicrons, triglyceride and cholesterol. Pathogenesis is clinical pancreatitis, eruptive or pruritic xanthoma. Second type is familial hypercholesteremia. It is the most commonly asked disorders. It is autosomal dominant. Here is pathogenesis is absent LDL receptor. Focus on LDL receptor is commonly asked. So ApoB100 enzyme is also defective. In blood we can see there is increased level of LDL and cholesterol. And in clinical mostly asked is tendon or Achilles xanthoma. In tendon xanthoma it is mostly Achilles xanthoma, accelerated atherosclerosis, corneal arcus or familial MI in young patients. Type 3 is dysbeta-lipoproteinemia. It is autosomal recessive. Here problem is defective ApoE enzyme. We can remember type 3 and ApoE. E looks like 3, so we can remember that. It in blood we can see chylomicrons and VLDL remnants are increased. Here clinically is premature atherosclerosis, tuberoeruptive and palmar xanthomas. So we can remember there are palmar xanthomas. In type 4 hypertriglyceridemia, it is autosomal dominant. There is hepatic overproduction of VLDL and increase in blood of VLDL and triglycerides. And clinical feature is acute pancreatitis. Of type 1 it is a pancreatitis with eruptive and pruritic xanthomas, but in type 4 it is acute pancreatitis. So we quickly revise hypolipoproteinemia. The most commonly asked is familial hypercholesteremia. It is type 2 where receptor LDL receptor is absent and tendon xanthomas are seen. So these 4 types of hyperlipoproteinemias are most commonly asked. We can remember them like 1 and 3 are autosomal recessive and 2 and 4 are autosomal dominant. So there are mostly questions on 1, 2 and 3. We can remember it.